Good day, and welcome to Epstein Becker Green's webinar, Eye on Ebola, a discussion about the health regulatory, risk management, and labor and employment issues impacting healthcare providers. We're pleased to have four fantastic speakers today. Epstein Becker Green's George C. Breen, who is a member of the firm in the healthcare and life sciences and litigation practices. He's also chair of the firm's National Healthcare and Life Sciences Practice Steering Committee and a member of the firm's board of directors. Frank C. Morris, Jr., a member of the firm in the Litigation and Employee Benefits Practice, heads the Labor and Employment Practice in the Washington, D.C. office, and co-chairs the firm's ADA and Public Accommodations Group. Amy F. Lerman, an associate in the Healthcare and Life Sciences Practice, and our special guest speaker, Dr. Bruno Petinaux, an associate professor, co-chief of the Emergency Management Section, Department of Emergency Medicine at George Washington University Medical Faculty Associates. Before we begin today's webinar, please be informed that today's webinar is being recorded and the participant phone lines will be placed on mute throughout the program. You're welcome to submit questions throughout the program by using the Q&A feature provided by WebEx, and at the end of the program, with time permitting, the speakers will address your questions. You are also welcome to submit questions directly to the presenters following the webinar. Contact information will be displayed at the end of the presentation. And approximately 2 to 3 business days following the webinar, Epstein Becker Green will communicate the availability of the webinar recording and access to the PowerPoint materials. At this time, I'd like to turn the webinar over to George Breen.
Thank you, and good afternoon, everyone. Thank you for joining us. Sadly, just today, the Ebola virus and its impact is front and center in the news headlines, as we learned this morning that surgeon Dr. Martin Salia, the latest Ebola patient to be flown to the United States for treatment, died at the Nebraska Medical Center. It was yesterday that we learned that travelers entering the United States from yet another country, Mali, will now be subjected to the same screening as those traveling from Liberia, Guinea, and Sierra Leone. Healthcare entities continue to deal with Ebola and the effects of Ebola in real time, but the import here goes beyond the current problem. Healthcare entities need to consider the lessons learned from the Ebola outbreak and to use this opportunity to assess current systems, existing policies and procedures, and to plan for the future, mindful of the challenges that may arise. Our hope today is that you'll come away from this program with practical information about the Ebola disease, as well as the operational, health regulatory, risk management, and the really unique labor and employment issues that are specific to healthcare providers, and to begin thinking about those issues on a proactive basis. We have an ambitious agenda today. We're going to begin with an overview of the Ebola virus and to address the how it's impacting the healthcare delivery system. We'll discuss the health regulatory considerations and the risk management considerations that folks ought to be thinking about. We'll also address the labor and employment considerations that that healthcare providers are uniquely faced with when we talk about Ebola. And we will follow with questions and answers. You were given information on how to submit questions. I would encourage people to try to submit questions as they are listening to the presentation. If we're able to do this, we will try to address questions in real time during the segment that we're talking about to make this as useful as we possibly can to people that are listening to the webinar. But we're going to begin today with a discussion of the Ebola disease and an overview, and we're really very happy that Dr. Petinaux was able to join us today. Dr. Petinaux is, as we indicated, an associate professor at the Department of Emergency Medicine at the George Washington University Medical Faculty Associates. He provides patient care in the emergency departments at the George Washington University Hospital, the Washington, D.C. Veterans Administration Medical Center, and the Walter Reed National Military Medical Center in Bethesda, Maryland. He serves as co-chair of the George Washington University Hospital's Emergency Management Program and as the Emergency Management Track Director for the George Washington University School of Medicine. He's a medical team manager for the Virginia Task Force 1 Urban Search and Rescue Team and serves as the chair of the District of Columbia's Emergency Healthcare Coalition. And I'll turn the program over at this point to Dr. Petinaux.
Great. Thank you very much, George, and good afternoon to all of you listening as well. We're very happy to see you join us, and thank you for taking the time out of your busy days to do so. We wanted to give you a medical overview of the Ebola virus disease, a disease overview, and then also examine the effects of the disease on the healthcare delivery focusing especially on the ease of transmission, the nonspecific signs and symptoms of the disease, the large medical waste that has been generated in hospitals with prior experience of dealing with such a patient, the impact that the media has on hospital operations, the interface with public health, as well as financial implications. The Ebola virus disease, when we are looking at it from a medical overview, we know that it probably resides in bats in Central and West Africa and has been first identified as a novel disease in 1976, having had outbreaks sporadically during the time period until this very recent, very large-scale outbreak. All of those have been rather smaller in scale, though did carry a very high mortality rate, as much as 90% of those afflicted by the disease. We know that those in the past who had been victims of this disease did not always have access to adequate health care. Hence, the 90% mortality rate has to be viewed in the context of the healthcare delivery. From a medical perspective, we know that Ebola is spread by direct contact with body fluids. Fluids such as blood, sputum, vomitus, or stool, sexually transmitted fluids such as semen and vaginal fluids, and sweat are believed and known to have the Ebola virus. This leads us in the medical community to develop certain protective mechanisms that we use, and we generally classify them as contact precautions, which means that we have to wear gloves in order to touch a body. And we also have to use droplet precautions, which means that if somebody were to cough, the fluid produced in a cough or sneeze to contain the virus, which means that we have to protect our staff from those transmissions. We do not believe that Ebola is airborne, and hence airborne disease precautions are not mandatory in the care of such a patient. Looking at the disease overview in terms of the exposure, we know that the exposure has an incubation period. This is the time of exposure to disease to becoming ill. It's 2 to 21 days, typically or often known to be 5 to 8 days in nature. During this incubation period, the patient is not infectious to other people. It is only once upon developing symptoms of the disease that a patient becomes progressively more infectious to others as they have more severe symptoms. The first symptoms that the healthcare community typically looks for are very nonspecific, which means that they are the same symptoms that we see with a number of many diseases, such as influenza and malaria and others. The first one is fever, though not always. But fever is the hallmark of the initiation where a patient becomes now symptomatic and the incubation period has ended. Malaise, nausea, vomiting, diarrhea, abdominal pain, and muscle aches are some of the other symptoms that we typically see early on in the disease process. Dehydration due to nausea, vomiting, and diarrhea play a large role in the illness of these patients. They must be hydrated appropriately. We need to give them IV fluids. We need to replace their electrolytes as they lose a lot of potassium and other electrolytes in the diarrheal fluids that are very large in volume. They may require support for organ failure. Kidneys may be affected due to the amount of dehydration. Dialysis would be the treatment for that. The lungs may become affected due to fluid shifts, for which life support or mechanical ventilation may be the result in that. Bleeding may also occur as the patients have the disease that affects their bleeding coagulopathy, which basically means that you may develop spontaneous bleeding in your stools, in your gums. It is as the disease has begun to ravage some of the platelets, some of the blood cells within your blood, and the ability to clot. All of these supportive mechanisms that we provide, we can do so in the United States of America, and we can provide the body with support. Some of the novel, non-FDA approved treatments that have been tried in the past include transfusion of the serum of survivors, novel medications, as well as novel vaccines. None of these are FDA approved at this point. As George has indicated, unfortunately with the death from today, we have to date treated 10 patients in the United States with a 2 death. We believe that the level of supportive care that these patients have received, as well as early and aggressive medical management, has probably helped to have an 80% survival rate, as documented in the United States. Certainly, possibly, the use of novel medications employed in some of these patients may have had an impact on the mortality rate. Next, I wanted to switch into the attributes that affect healthcare. Ease of transmission, nonspecific symptoms, medical waste, media impact, public health, as well as financial implications are all some of the planning components that our institution has to grapple with as we plan for this disease. As is well known, we have not seen such a patient at our facility to date, and hence a lot of these questions that we're bringing up are those that we developed in our planning process. Some of the assumptions that I have outlined so far in this presentation have led us to some of the operational components that I will now cover. So we know the disease is transmitted fairly easily through body fluids. We know that healthcare workers have been affected in West Africa as well as in the United States by this disease. Therefore, my staff may be reluctant to care for such a patient. Today's unfortunate example of the death of yet another healthcare worker illustrates the importance of staff protection. We know that a very high level of personal protective equipment is necessary to care for such patients. That is in order for our staff to remain disease-free in the care and not have to worry about occupational transmission. This increased personal protective equipment may come to levels that we don't normally stockpile in our medical facilities. It also illustrates that we have to have robust training and education for our medical staff in terms of the donning, which is the putting on, as well as the doffing, most importantly, the removing of the personal protective equipment. We need to ensure that we enforce strict protocols for the safety of our staff. These are operational protocols to ensure their safety in caring for such a patient. And we also need to make sure that we screen our personnel appropriately so that those that are wearing the personal protective equipment can do so safely. Due to the complexity of the personal protective equipment in terms of wearing masks and gowns and gloves, it is very hard to work very long shifts as the equipment does get very hot. We have to balance minimizing the staff number contact with the patient with the shorter time period that our staff is able to work in those shifts. We also have to re-examine what kind of patient contact we're looking to do and how we minimize the number of staff members. Call those the direct care providers, which are those that put their hands on the patient. We may need to review how we traditionally deploy our hospital personnel, for example, dietary. Should we have a dietitian bring in the tray into the patient's room? Or could possibly the direct care team actually do that function, which would decrease the amount of personnel that enters and exits the room? Looking at slide 16, when we are now looking at the processes that we put in place to protect our staff, we have to ask the question of what if it fails? Unfortunately, we have seen such an example of a failure of the protection and in occupational exposure. So how do we limit the activities of staff who have cared for an Ebola virus disease patient? How do we do so prospectively? We know that the incubation period is 21 days, and that is a very long time period to maybe ask staff members to remain at home. Where do they stay at? Do they stay at home? Do they stay somewhere else? Who pays for it, and how is this done? Many questions now arise, those questions that affect the personal lives of our staff members. If a hospital does not feel adequately prepared to handle such a patient, can a hospital turn away an ambulance, which would be bringing a suspected Ebola virus disease patient? Can a hospital, on the contrary, look to transfer such a patient from a lower level of care to a higher level of care? Hospitals do this on a daily basis as we transport patients with specific illnesses such as heart attacks, trauma, or strokes to higher level specialty medical centers or burn victims or pediatric patients. Can we do the same thing with Ebola virus disease as well? The nonspecific symptoms that patients present with are a very big challenge. As we're entering the flu season, I'm sure that many of us can identify with Ebola-type symptoms. fever, malaise, headache, nausea, vomiting, and diarrhea. Many of these symptoms we see with our seasonal outbreaks of influenza and other viruses. For those that have traveled from abroad, malaria is a very prominent illness in West Africa. So is infectious diarrhea. So these are all diseases that may present very similarly, and we have to make sure to identify the right patients quickly. To identify the right patient quickly, we use travel history, which is very critical because we believe that travel history is somewhat related as Ebola is concentrated in one geographic area. We also have to keep in mind that this does not only affect our patients, but also our staff that may be traveling for personal reasons to the affected area. The contact history is critical. If you've traveled to the area but never had contact with an Ebola patient, it is extremely unlikely to really not likely at all that you could contract Ebola. On the other hand, having contact with an Ebola patient anywhere in the world is a very serious risk factor. This also includes the question of how do we care and how do we examine healthcare workers from the United States that have gone to take care of Ebola virus disease patients in West Africa and are now returning back to the United States to provide healthcare again in their communities. We also know that travel and contact history did not always apply to some of the New York City cases, as that was a case that was in the United States of America. Medical waste is another issue. It seems that Ebola virus disease patients generate a very large amount of medical waste. We certainly are accustomed to caring for medical waste in the hospital. We have patients with tuberculosis, HIV, hepatitis, and a number of highly infectious diseases in our medical facilities every day. We also know that all of these viruses and diseases will eventually die when they're outside of the body after a certain time period. The environment does not provide all of the regulation that a virus needs to survive in a host. We also know that the United States Department of Transportation has classified Ebola virus disease waste as a Category A waste. This results in very complex packaging and permitting processes, which healthcare facilities need to be very much aware of. Public health implications. The public health departments need to provide for contact tracing of any Ebola virus infection in the United States. The best way to really prevent it is to identify patients early on. We talked about the incubation time period, which is up between 2 and 21 days, typically 5 to 8 days. During this incubation time period, public health departments can go out and identify anybody that might be at risk, provide them outstanding instructions, be able to track those contacts as well, so that we can go ahead and identify any additional disease outbreaks early on. So this needs to be done while the initial patient was symptomatic, because again, if they were in the incubation period, they are not going to be at risk of transmitting the disease. They need to institute a strong surveillance and monitoring process of those that are in the incubation time period. The focus of the media is another strong component of this that we all have to be attuned to. As we know that the existing Ebola virus disease patients, those that have been cared for in the United States, have attracted a lot of media coverage. It's very important that we maintain the privacy of these patients, that we maintain a very dignified environment with which to care for them. Wrapping up some of the planning components that we have looked at are the financial implications. The preparedness efforts for the care of an Ebola virus disease patient are very large. The planning, the training, the equipping, and the exercising in the healthcare setting for these patients to ensure the safety of our staff is paramount. We have to get this right. It is expensive to do so, as we are bringing in staff members for training, if we're purchasing additional personal protective equipment, as we're training and exercising. These are all activities that are removing our staff from all the other day-to-day healthcare activities that we're accustomed to performing. We also are concerned about the presence of an Ebola virus disease patient. Could that impact the volume to your facility in terms of ER visits, in terms of elective procedures, as we know that our public has many healthcare choices and therefore may elect to go to another healthcare facility than yours, which may be caring for an Ebola virus disease. As you can see, some additional resources, very generic here, is that the CDC has put out a lot of guidance. We urge you to examine that guidance. We urge you to also speak with your public health department as well as your local healthcare preparedness coalitions that you may have in your region to prepare your facility and your community for the care of such a patient. Thank you very much.
Thank you, Doctor. Let's turn now and take a look at some of the health regulatory issues that healthcare entities should be thinking about in connection with Ebola and similar diseases. And Amy Lerman, I'll turn this over to you to share some thoughts you may have in that area.
Okay. Thanks, George, and thank you, Dr. Petinaux, for joining us today. Over the last couple of weeks, as the media coverage of Ebola has literally exploded, some common themes have emerged, and as George said during his introductory remarks, one of these themes, particularly for healthcare providers, is the notion that now is the time for providers to assess and to plan for future infectious disease outbreaks, Ebola or otherwise, that may affect their normal course of business, both the patients they treat, as well as putting their workers, the healthcare professionals, at some degree of risk. This actually is not a new train of thought by any means, just as we're learning so much from the current Ebola outbreak that will help to improve healthcare workplace policies and procedures. Important lessons have been learned in the past from other noteworthy infectious disease outbreaks, including severe acute respiratory syndrome, or SARS, the avian influenza, the H1N1 virus, and as all of these events have illustrated, pre-event preparations are key to responding when these outbreaks hit. And we don't know when the next one will, so it's time to think about some considerations that can help our planning now. Infectious disease outbreaks like Ebola have been interesting tension for healthcare providers. On the one hand, as Dr. Petinaux was saying, providers have to deal with the outbreak and have to be prepared to cope with a surge of potentially, infected patients, however big or small it is. But on the other hand, providers have to maintain their normal course of business and the existing demand for healthcare services throughout the facility. As we all know, healthcare is a highly regulated industry, but the reality when an infectious disease outbreak occurs is that certain legal and regulatory standards that traditionally govern the provision of healthcare services, and in particular the actions of the providers, may warrant some special attention. What may work in the normal course of business to regulate the practice of healthcare may need to be recalibrated in the context of dealing with infectious disease outbreaks like this. And so providers really need the ability to be flexible and as responsive as possible. So we thought of some considerations that, providers should be thinking about. The first one I'm going to talk about is scope of practice and licensure. Even with so much regulatory activity at the federal level, as many of you know, the everyday practice of healthcare is quite regulated at the state level, where individual states have long retained sovereign powers to define both the practice of medicine as well as to select, regulate, and discipline providers who practice within their boundaries. So why is this relevant to Ebola? The adequacy of the healthcare workforce is a key consideration when thinking about how to deal with infectious disease outbreaks. It could be in question of whether there are enough healthcare workers to handle a potential surge of new cases, or whether a facility has the right types of providers to deal with the cases that can come through the door. Either way, it could be necessary to recruit additional workers even from outside the state, and that way there would be adequate and appropriate professional support during the outbreak. However, the need to cross state lines in this event can be challenging in light of state scope of practice and licensure laws. All states define what the practice of medicine means within their state and may or may not include in that definition activities related to provision of care at a distance, in other words, outside their state and another state. Similarly, state licensure laws can be a significant compliance hurdle for providers who seek to practice across state lines. The multi-state licensure process can be time-consuming, costly, and inefficient to navigate. Some states do provide exceptions for cases of emergencies, but not always, and often these are limited in scope. So providers have to consider potential challenges related to scope of practice and licensure if the need to mobilize a larger workforce were ever to arise, and at least should follow some efforts that are being made more globally to advance the idea of license portability. For example, the Federation of State Medical Boards this past September completed its drafting process for its interstate medical licensure compact, and under this compact, a physician who is licensed in his or her principal state and who met certain educational, certification, and disciplinary criteria would be eligible to apply for an expedited medical license in another state that has adopted the compact. So it would be, as states were to adopt it, a way to improve license portability for physicians. And, physicians in turn would have more mobility and could fill critical needs for certain types of care where it's most needed. This has generated a lot of excitement in the telehealth community, but it shouldn't be overlooked as a consideration when providers are developing and refining pandemic preparedness plans. Similarly, the National Council of State Boards of Nursing Nurse Licensure Compact was actually the predecessor. It was launched in 2000 and expanded the mobility of nurses by allowing nurses to have one multi-state license that gives them the ability to practice in both their home state and other states that have adopted the compact, of which I believe there are currently 24. A second consideration, similar to scope of practice and multi-state licensure, is credentialing and privileging. Concerns, again, about adequacy of the workforce when an organization is faced with an infectious disease outbreak prompt similar questions about how the organizations can check providers' credentials, grant, or even limit privileges to practice in those organizations. Again, relevant to Ebola because an infectious disease outbreak might be completely indifferent to any artificial catchment or service area, and accepted means for checking credentials and granting privileges could become irrelevant in light of healthcare workforce needs. Healthcare providers might need to move from one facility to another without regard to institution-specific standards, and organizations might even have the need, depending on the scale of a pandemic, to train volunteers. People who are not trained and licensed, potentially. How could those individuals be properly screened and validated under an organization's traditional credentialing policies? Again, an idea that organizations should be using the opportunity we have now to plan ahead for the future and ensure that perhaps their existing policies are sufficiently flexible to accommodate these considerations were a need ever to arise. Patient data privacy is our next consideration. It's consistently been part of the Ebola discussion. Dr. Petinaux mentioned it. Certainly not surprising since there's such intense public interest in the spread of Ebola. However, this curiosity just does present a challenge for healthcare providers who are treating the patients. On the one hand, healthcare providers are bound under HIPAA as well as any applicable state laws to safeguard privacy of patients' information. They have a duty of confidentiality to all patients, especially when dealing with something like Ebola, where both patients and their families can be subject to intense media scrutiny. And as we've seen with the handling of many of the U.S. Ebola cases in the media, at least, a significant challenge in maintaining this confidentiality is that so many people legitimately may have access to that patient's information. In addition to physicians, nurses, hospital administrators, the identities of Ebola patients likely are known to, just to name a few, environmental services staff, billing and insurance staff, state and federal government officials. There are also potential disclosures to anyone who might need to be notified about potential exposure to Ebola through contact with one of those patients. Although all of these individuals are constrained to some degree by laws against breaching a patient's confidentiality, all it takes is one person to leak, and then the media picks up on it, and the details are widely available. And Ebola is a disease about which the general public needs education and guidance. However, providers have to consider that HIPAA does not provide disclosure exceptions for medical conditions merely because they're newsworthy. There are exceptions to HIPAA related to public health and safety, such as disclosures to public health authorities for reporting of communicable diseases. However, exceptions of this nature generally don't permit covered entities or their business associates to release PHI to the media or to the general public. However, keep in mind as well that HIPAA applies only to covered entities and their business associates and doesn't restrict what information patients or their family members, clergy, friends, neighbors may legally disclose or what a patient might give his healthcare provider authorization to disclose. Earlier this month, the Department of Health and Human Services Office for Civil Rights released a guidance bulletin entitled HIPAA privacy in emergency situations. It's a helpful guidance that you should definitely consider reading that covers some of these parameters for the sharing of patient information and also for safeguarding the information. Let's look at an example, however, because patients with any greater than average degree of notoriety require extra measures of security, and that seems to be the category that these patients are falling into. Various recent technology surveys have actually concluded that snooping is a major problem for data breaches, and a strategy which some providers have used in connection with treating these VIP patients, be it a celebrity or an Ebola patient in this case, is checking the audit trails of their EHR systems to ensure that no employees get too curious. And that's exactly what happened in earlier in October at the Nebraska Medical Center and resulted in the firing of 2 medical center employees. During an audit of the medical center's EHR system, hospital officials discovered that these employees had inappropriately accessed the record of Ebola patient Dr. Rick Sacra. The medical center conducted an investigation which resulted in the terminations of both employees, and in accordance with HIPAA regulations, the doctor was notified in person and in writing before his departure from the hospital. The medical center said they had a no-tolerance policy, and the employees were terminated. Moving on to consider the FDA's role in Ebola. Treatment of Ebola obviously not only includes use of vaccines and other medications, but also the use of medical devices and other types of diagnostic equipment, many of which are regulated by the FDA. The FDA is currently playing various roles with regard to managing the Ebola outbreak, as they've done in other infectious disease outbreaks, including the sharing of information. They're sharing information about medical products in development and assessments of product readiness, as well as clarifying regulatory pathways for development. They're working with other agencies. They're working with governmental agencies that fund product development, as well as international partners and private companies to help speed the development of medical products that could be used to mitigate the Ebola outbreak. An example of this is the 21st Century Cares Initiative, which was launched actually back in the spring. It's aimed at accelerating the pace of cures and medical breakthroughs in the U.S. The initiative is taking a comprehensive look at the full arc of the drug development process, from discovery to development to delivery. The FDA is also working with medical product sponsors to clarify regulatory and data requirements that are necessary to move products forward in development as quickly as possible, and utilizing all of its agency-specific powers and processes, including the emergency use authorization, where they can consider whether to enable the use of unapproved medical products or unapproved uses of approved products during emergencies, and also considering whether to enable access for individuals to investigational products through mechanisms outside of the clinical trials process, such as investigational new drug applications submitted under the Expanded Access Program. The FDA is also monitoring, unfortunately, for fraudulent products and false product claims during outbreak situations. These are unfortunately quite common, and they're monitoring for these fraudulent products and these false product claims and taking appropriate action to protect consumers. Back in August, they issued a statement warning consumers, for example, about the potential for fraudulent Ebola treatment products. And finally, they're encouraging development of treatments for Ebola using pathways such as their orphan designation and their other drug development programs. They are hopeful that these efforts will provide incentives to encourage companies to invest and develop treatments for rare diseases like Ebola, with the ultimate goal of getting safe and effective products to U.S. patients as quickly as possible. The FDA also has collaborated closely with the European Medicines Agency on orphan designation for many years. Developers of Ebola medicines have actually been encouraged to submit applications for orphan designation both to FDA and the EMA in parallel to help speed the development process for these products globally. Despite the FDA's efforts, however, as Dr. Petinaux said, currently there are no FDA-approved treatments for Ebola. There are certainly some experimental vaccines and some other treatments, and some investigational therapies have been authorized by the FDA under expanded access, but currently everything is technically still under development. So this means, at least for the time being, that if more Ebola patients present at U.S. hospitals, hospitals have to decide whether to utilize unapproved therapies. There are specific parameters under which FDA allows access to unapproved treatments and in very limited instances. So the possibility that organizations or user facilities would consider treating Ebola patients, it raises several considerations. The first being informed consent, because the failure to obtain proper informed consent from patients before treating them, particularly if using unapproved therapies, can result in potential negligence litigation, not to mention imposition of sanctions by the FDA. George is going to discuss informed consent a little more during his part of the webinar. There are also considerations regarding FDA authorization and Institutional Review Board, or IRB, approval, because user facilities that wish to treat patients with unapproved therapies need authorization and approval from both of these bodies before moving forward with the treatment. There are also adverse event reporting obligations. Facilities have to consider what obligations they may have in the event of a suspected device-related death or a serious injury. For example, what if a hospital worker's PPE fails and results in that worker being infected with the Ebola virus? Does the hospital have reporting obligations to the manufacturer of the PPE, to the FDA? There are lots of questions. Similarly, on the manufacturer side of things, there are some other considerations. Certainly, the question of adverse event reporting if something were to happen. There are obligations that manufacturers have to prevent contamination of products. Will more likely to establish and maintain specific procedures that prevent contamination. They have to be specific to and appropriate for the products being produced. For example, the manufacturer of a sterile medical device must implement more stringent controls than the manufacturer of a device that's not intended to be sterile. And finally, content of communications with the public. Manufacturers of products that are intended for use in the treatment of Ebola patients must use care when communicating with the public regarding their products in light of all the heightened media attention around Ebola. Manufacturers should avoid making any specific claims regarding the use of their product to treat Ebola patients if the product's FDA-approved or cleared indication is not specific to Ebola, or if the product is investigational. If a manufacturer makes any claims regarding the use of their product to treat Ebola patients or for any treatment purpose, such claims have to be appropriately substantiated. A final consideration is the questions about the cost, the coverage, and the reimbursement for Ebola treatment. Questions regarding cost are particularly interesting among private payers, as there's room for much more variability among these payers with regard to coverage policies and the amount that providers are reimbursed under policies for providing treatment. Most payers use networks of providers and either do not cover care provided outside a network or cover it at a lower rate of reimbursement. If it remains the case that only certain facilities in the U.S. are accepting and providing treatment for Ebola patients, there could be questions around whether payers would agree to treat these facilities as participating in their networks or non-participating. And if a patient was then sent to a non-network facility for treatment, could the payer classify the services as out of network and not cover them at all, or provide coverage that's subject to higher coinsurance, deductibles, and potentially limits based on usual, customary, and reasonable costs, leaving the patient with a very large bill? It seems unlikely that payers would not agree to include the facilities that are currently treating Ebola patients in their provider networks, especially if they've already been part of these networks. However, in the short term, this may be a consideration for some payers as they evaluate the extent of their coverage for treating Ebola patients. Treatment also raises questions regarding how payers choose to define the outer boundaries of their coverage. Treatment for Ebola is labor-intensive, as Dr. Petinaux described. It requires use of specialized gear, and it can continue for an extended period of time. So payers may be starting to use the Ebola treatment experiences that have occurred to date in order to determine whether all of the treatment and the gear and everything should be covered under their policies. Then we can switch for a moment to public payers. Certainly there are some interesting compliance considerations. One would be the Medicare conditions of participation. Medicare has various conditions of participation that are specific to hospitals as well as other types of providers, at least several of which are called into question when a hospital is tasked with treating an Ebola patient. They serve as the basis for survey activities that are conducted to determine whether hospitals actually qualify for their provider agreements under Medicare. A violation of a Medicare condition of participation by a hospital potentially could result in termination of that hospital's Medicare provider agreement. It's hard to say how likely enforcement by CMS under such circumstances would be in the context of a hospital's response to Ebola, but technically it's possible based on the letter of the law. Finally, earlier this month, I wanted to point out that the Office of Personnel Management issued guidance to all of its carriers that serve the members of the Federal Employees Health Benefits Plan, which would be federal government workers. And federal workers from numerous agencies are assigned to duties around the world, including in West Africa, so it raises concerns on their part about exposure risk. The recent OPM guidance focuses on responsibilities that these carriers have for handling the members who may be exposed to the Ebola virus. So certainly it is worth considering, as guidance that would be relevant. Before I pass this back to George, fortunately the current Ebola outbreak has not grown anywhere close to pandemic proportions, and hopefully it never will. But as I said at the beginning, healthcare professionals and organizations should take advantage of the opportunity to consider these regulatory considerations, especially now while there are opportunities to plan without being under the pressure to actually execute. We're going to shift the discussion now to risk management considerations, and I will turn back over to George.
Thanks, Amy. So I think one opportunity that healthcare providers and entities have here is to look at both issues specific to Ebola but also to their overall risk management program, and to assess if they have policies, procedures in place to be able to address these issues, because I think there are issues that, as we've talked about, that really go beyond the Ebola disease. So we'll talk about a few of the issues that we think are particularly pertinent as a result of the outbreak of Ebola. And the first that really comes to mind is the issue of policies and training. The reality is this situation, and it struck me consistently, is fluid. And what may be standard practice, what may be appropriate protocol today may not have been standard practice or appropriate protocol 2 months ago. And the reality is that organizations have to appreciate the fact that this is a fluid situation and need to be able to be prepared to adapt and to address new guidance as it comes forth. So there is a need to be able to monitor the developments reported by international, national, and local health authorities to make sure that your entity is up to date with and in compliant with the most current protocols and best practices. That may mean that protocols and policies get written and then rewritten to be able to develop and to adapt to the most current thinking, the best practices that exist. That also means that the reality will be a need to train and to retrain staff. What staff needs to know today, they may not have needed to know 2 months ago and may be obsolete 6 months from now. There is an increased need to be able to make sure that you have trained and updated your staff on a routine basis on best practices to make sure that you are acting in a fashion that's best suited for your organization. As you are training, as you are creating different policies and procedures, you're going to want to make sure that you've documented that. You're going to want to be able to make sure that you've documented that the condition that existed as of a particular date is one that you are operating on with the then most updated policies and procedures, with those that are the most updated protocols. Your documentation as it relates to that is your first line of defense. If someone suggests that you are not operating within best practice, you'll want to be able to demonstrate the steps that you took to be able to assess what best practice was, what current best thinking was, and that you reacted and responded accordingly. Auditing is a key portion of this, because training and the creation of policies and procedures are fine, but you have to make sure that the training is understood and is in fact put into place. Has the training that you've offered to your staff been one that they have accepted, developed, and if you put it in real practice, is it being utilized in the fashion that you anticipated? If it's not been utilized in the fashion you anticipated, how are you assessing that, and what are you doing to change to ensure that corrections are made so that best practices continue to exist within your organization? You're going to want to make sure that you have assessed the impact of training. There may need to be different training. There may need to be additional training as you see whether or not this is actually progressing in real life, real-time situations. You must intervene if there are lapses and be able to determine why there is that lapse. We'll talk about in a few moments documentation that gets created as part of this process and some of the concerns and considerations you ought to have as you're creating this documentation to be able to best protect your organization. Communication, as I think we have experienced through the outbreak of Ebola, really is critical. And organizations ought to be able and need to be able to manage the flow of information. Speaking through multiple voices is rarely the best practice. And as we have seen, when different voices speak, different pieces of information get shared. Organizations need to control the message. Now, whether that means that there's a crisis management response team that the organization develops, whether there is a separate PR team, you're going to want to make an effort to make sure that you are speaking through one voice. There's a specified individual or group that handles inquiries, that addresses press inquiries, for instance, and responds accordingly, so that you are speaking through one voice and you are delivering one message. If there are press inquiries, should those inquiries and the response to those inquiries be reviewed by your legal department to make sure that you are sending the message that you want to send? You want to be able to manage the flow of information as best you're able to do that in connection with and while considering how that reflects on your organization. It is an unusual circumstance where multiple people speaking for the organization ultimately benefits the organization. The issue really here is how you can best manage the flow of information. But communication is both internal and external. So while we can talk about how the flow of information ought to flow to the outside world, there needs to be a recognition that the internal audience, your staff, needs to hear from you, and the communication to the internal staff needs to be managed as well. That means multiple people communicating to the internal staff can create issues for the organization. So what's the message you're able to best send to your internal client? Meaning, how can you pass on information in the most effective way to existing employees, to current staff, to best manage the situation? And there ought to be a process behind that. That time for creating either the internal response or the external response is not at the time the event happens. There needs to be a policy and practice in place to be able to turn on once these situations arise, because you've lost the opportunity to manage the flow of information both internally and externally absent that. So as you consider the issues relative to Ebola, you're going to want to look at your communication policies. Do you have one? If you have one, does it provide for a flow of information both internally and externally? Are people speaking through one voice? Is that the right voice? Is the voice that speaks to the external audience the same voice that speaks to the internal audience? There are differences, and use this opportunity to be able to assess whether your communications practices are in fact best practices, or whether there needs to be some revisions to those practices. The Emergency Medical Treatment and Labor Act is one of the areas of the law that comes into question when you're dealing with Ebola and similar issues. It requires anyone coming to an emergency department to be stabilized and treated regardless of their insurance status or their ability to pay. It's commonly referred to as the anti-dumping law. It requires Medicare participating hospitals with emergency departments to screen and treat the emergency medical conditions of patients in a non-discriminatory manner to anyone, regardless of their ability to pay, their insurance status, their national origin, their race, their creed, or their color. Now, how does EMTALA define an emergency? Under the law, an emergency medical condition is a condition manifesting itself by acute symptoms of sufficient severity, including severe pain, such that the absence of immediate medical attention could reasonably be expected to result in placing the individual's health in serious jeopardy, serious impairment of bodily functions, or serious dysfunction of bodily organs. EMTALA implies when an individual comes to the emergency department. Now, that's critical because when you look at the definition that CMS has offered to that, CMS defines a dedicated emergency department as a specially equipped and staffed area of the hospital used a significant portion of the time for initial evaluation and treatment of outpatients for emergency medical conditions. This means, for example, that hospital-based outpatient clinics that aren't equipped to handle medical emergencies are not obligated and subject to EMTALA. Hospitals generally have three principal obligations under EMTALA. First, an individual who comes in and requests it must receive a medical screening exam to determine whether an emergency medical condition exists. Examination and treatment cannot be delayed with regard to questions about ability to pay. Signs must be posted in the emergency departments to notify patients and visitors of rights to a medical screening, examination, and treatment. If an emergency medical condition exists, treatment must be provided until the emergency medical condition is resolved or stabilized. If the facility doesn't have the capability to treat the emergency medical condition, an appropriate transfer of the patient to another hospital must be done in accordance with the EMTALA provisions. Hospitals with specialized capabilities are obligated to accept transfers from hospitals who lack the capability to treat, and a hospital must report to CMS or the state survey agency any time it has reason to believe it may have received an individual who's been transferred in an unstable emergency medical condition from another hospital in violation of EMTALA. EMTALA also governs how patients are transferred. A patient is considered stable for transfer if his or her treating physician determines that no material deterioration will occur during the transfer between facilities. But if the patient is unstable, what happens? If the patient's unstable, he or she may not be transferred unless a physician certifies the medical benefits expected from the transfer outweigh the risk, or a patient makes a transfer request in writing after being informed of the hospital's obligations under EMTALA and the risk of transfer. And the transfer must be appropriate under the law, which means the transferring hospital must provide ongoing care within its capability in order to minimize the transfer risk. The receiving hospital must provide copies of medical records. There must be a confirmation that the receiving facility has space and qualified personnel to treat the condition and has agreed to accept the transfer, and the transfer must be made with qualified personnel and appropriate medical equipment. There are violations for the failure to comply with EMTALA, both administrative and under civil law. In terms of the administrative potential penalties, there's the potential for the termination of the hospital's Medicare provider agreement. There's the potential fine of up to $50,000 per violation, although it's $25,000 per violation if the hospital has fewer than 100 beds. There's also the potential for physician fines of $50,000 per violation. You also have the exposure to civil action, civil negligence claims for personal injury as a result of an individual claiming damage as a result of the hospital's violation of EMTALA. And if the receiving hospital suffers some financial loss as a result of another hospital's violation of EMTALA, that facility can bring suit to recover damages. Remember that there's no violation of EMTALA if a patient refuses examination or treatment, so long as there's no evidence of coercion. One of the things that you need to be sensitive to is to make sure that you have the appropriate EMTALA policies and procedures in place. Use this opportunity as a chance to be able to review those policies and to make sure that your staff is acutely aware of the obligations under EMTALA so that you don't find yourself facing a potential administrative sanction or the potential for a civil cause of action. One of the things Amy mentioned was the issue of informed consent. The reality is that if Ebola patients present at U.S. hospitals and certain medications that haven't been approved, the hospital is going to have to decide whether to administer the improvement drugs to these patients. But to do so, there must be informed consent. Informed consent laws vary state to state, but in general, a provider is required to advise the patient of all of the potential benefits, risks, and alternatives involved in a course of treatment and must obtain the patient's written consent. Recognize, though, that that's in many ways a fact and circumstance-dependent analysis. What is the condition of the patient at the time he or she is being advised of the benefit of this unapproved medication? There really needs to be an assessment, and one of the things that risk managers ought to be thinking about as they consider what the lessons may be from the Ebola outbreak is whether the appropriate informed consent policies and procedures exist, whether patients and whether staff are advised of and aware of and are implementing the informed consent policies and procedures, whether your forms that you use to document informed consent are accurate and up to date. Use this time to assess that to be able to determine whether or not you have in place the best practices to ensure that if there's a challenge, you in fact did provide an individual legitimate informed consent, because that will be one of the areas people will look to in a potential negligence claim for having had a lack of informed consent. From a risk management perspective, you're also going to want to consider what your insurance coverages are and what the liability limits are for the insurance coverage. Do you have the right insurance coverages in place? Do you have the right amounts of liability? So for workers' compensation, do you recall that and remember that if an employee is damaged, is injured because he or she has treated a patient with Ebola, there are significant costs associated with that. Full isolation protocols are tremendously expensive. Will the policy cover that full isolation protocol? You have to be able to assess whether that, in fact, is a policy that you have with sufficient limits. If you employ workers overseas, do you have a workers' compensation policy that will apply to those workers? And if you do, what conditions does that policy cover? Does it cover a disease such as Ebola? Rumor has it that there are some insurers that are considering writing in Ebola exclusions into policies. Do you have the right policy and procedure in place? Business interruption insurance. The challenge to business interruption insurance is that typically they trigger only if there's been a direct physical damage or loss to an insured's property. However, policies can be created so that there's not a need for actual physical damage in order to trigger the business loss. Again, you need to look at the business insurance policy that you have or consider obtaining one to determine whether or not its limitations fit a situation such as this, and to fit the situation you typically find your institution in, use this as an opportunity to determine whether or not you have the right coverages available to your business. Environmental liability. If you have that coverage, they may also provide some coverage depending on its specific terms and conditions. For instance, you may be able to recoup lost income from a contamination incident under a pollution legal liability or PLL policy. Now, they sometimes contain specific conditions relative to infectious disease. There may be co-insurance or other limitations, but they may also provide coverage for cleanup, storage, transport, and the disposal of medical waste that Dr. Petinaux talked about, and the expense attenuated with that. Directors and officers liability insurance, a must-have, and you really want to make sure that you have and you are complying with the terms and conditions of that policy, particularly to the extent there's any reason to believe that you've been placed on notice of an actual or potential claim. A D&O policy will often provide coverage for claims where there has been some level of mismanagement, where there's been an allegation that the policies, procedures, and protocols were not the most appropriate. So you're going to want to make sure that you are acting in compliance with your D&O policy and that you have a coverage that is specific to your institution and with regard to the issues that you address. There are other issues to talk about as it relates to Ebola, the most significant of which, from the purposes of this discussion, really is documentation. The reality is, unfortunately, that as you document what you are seeing, you may be creating Exhibit Number 1 and Exhibit Number 2 to the first lawsuit against you. And you need to think about how it is that you are documenting what you are seeing. If, for instance, you are finding training has lapsed or has not achieved what you anticipated achieving, how are you documenting that? If you are investigating the quality of care that a patient is receiving, how are you documenting that? Remember, there is no federal peer review protection. So the documents that you are creating, you want to be intelligent about and consider what it is that you're reporting and how it is that you are reporting it. As much as we said at the opening that documentation can be your first line of defense, it can also be the first evidence used against you. So you want to consider how and what you document and what practices you have in place for that. If you are not, it may be time to consider whether you become a member of or establish a patient safety organization. A patient safety organization established under federal law is designed to be able to report issues involving the improvement of patient safety and healthcare quality. One of the benefits for a patient safety organization is that it creates a privilege for patient safety work product. Patient safety work product is protected from disclosure under the patient safety rule. What that means is that any documentation that's created and shared under pursuant to a patient safety organization under the Patient Safety Act and rule makes those documents privileged and confidential. Subject to very specific exceptions, patient safety work product can't be used in criminal, civil, administrative, or disciplinary proceedings. That's a significant advantage that people need to think about whether they should be taking an opportunity to consider that they can be benefiting from. And when you look at Ebola and issues presented with Ebola, you ought to be thinking about what are some of the benefits you might gain from becoming associated with a patient safety organization, and how more generally you are reporting your analysis and your assessment as you are reviewing and re-reviewing not only staff training and performance, but also the manner in which you're providing care to patients. Remember, you need to appreciate your facility and its capacity. You need to realistically assess what you can and cannot do, what you can and cannot provide. You're going to want to monitor your staff that are caring for these patients to make sure that there's a care protocol in place to care for them, because you do have an obligation to provide and to protect your hospital staff and your employees. With that, Frank, we're going to turn to you and ask you to walk us through some of the employment and labor issues that are really unique to healthcare providers. Healthcare providers are really on the forefront here, and issues that healthcare providers deal with are unique to the labor and employment industry generally.
Thanks, George. And I will say as one segue point, with your very comprehensive discussion of EMTALA, really there is a second set of obligations potentially on the healthcare provider that's confronted with providing care to an individual who may have Ebola. And those flow from if Ebola is in fact covered by the Americans with Disabilities Act as a disability. The institution may have an obligation, because healthcare institutions are specifically called out in the Americans with Disabilities Act as public accommodations, to not discriminate against an individual and to provide the same services that it would provide to anyone else who is not disabled. And for those who are participants in Medicare, Medicaid, or other federal programs, therefore federal financial aid recipients, they would have similar obligations under the Rehabilitation Act of 1973. And I mention that in particular because as you spoke about the potential remedies available to someone for an EMTALA violation, while the ADA would generally provide injunctive relief, attorney's fees, and so forth, under the Rehab Act, the broad regular spread of damages would be available. So that's yet another area where the healthcare community has to be cautious as to how they deal with this, but I think the same analysis would still apply that you gave with regard to whether or not the institution is in a position to provide the right care to someone with Ebola. So without further, I'm going to pass by this pretty quickly, this first slide, because really what we've seen here is Dr. Petinaux has really given us an excellent overview on the medical side of what we're looking at here. Our focus today really, and as Amy mentioned, this is both for Ebola focused and at the moment, because there are other infectious disease situations that are out there, there are other potential pandemics. And what we really want to look at is the approach from the employment law side of how we might face any of these infectious disease situations. And so much of the healthcare community, whether it be first responders, EMTs, fire and rescue, all of the healthcare providers, from the physicians through every spectrum of those who provide the care, to those who are involved in transport, to those who are involved in the medical waste, are all going to be exposed to some of the issues that we now talk about. So the first question, and one of the questions that has come into us during the course of the program, was how can we give any comfort to those who are involved in caring for Ebola patients. And much of what I'm going to talk to you now about is really providing just that kind of comfort. And it starts with, and Dr. Petinaux, I think, gave you a great discussion, really, of the educational process and the intra-communications of the hospital community, the healthcare community in the metropolitan area here and the tri-state area. All of this is part of what we really need to be looking at, which is educating those who are going to be involved in providing the care and also keeping them up to date with the requirements, whether it be from the state health department, whether it be from the CDC, all of those who are involved, letting our employees know what precautions that we have taken, what preparations that we have put in place as to how, if we are confronted without a lot of notice with a patient who may be presenting Ebola-like symptoms, how we are going to properly prepare to care for that person and at the same time protect our employees. And so letting employees know that this is not something that when the patient rolled up to our door that we first now started thinking about, but rather that we put careful planning into place, that we have both policies and equipment prepared so that we are in a position to provide care in a safe way. And that's really going to be a critical part of this. And also, as George was relating, again, having that appropriate point of contact. And I think here, as George said, it's important that we speak with one voice. Now, that one voice may need to be informed, as just as we've done today, I think, from those who are clinicians who understand all of the issues from the medical care provision side, as well as those really from the human resource and risk management side, and melding the talents of a team of that sort together so that we can give the right answer to all of the kinds of questions and concerns that our workforce may have in addressing these issues. And by doing so as well, as Amy talked about and as the doctor talked about, we have those concerns about what happens to our perception in the community and whether we're going to see patients who would otherwise be coming and leaving. A great deal of what we are doing from the employee perspective will help position us in the community so that we don't suffer a mass exodus of our patient population. And so it really all works hand in glove as to how we are going to deal with these kinds of situations. So we should have that crisis communication team. I would, again, I think it's a team, but then we designate probably one person to be the spokesperson. Unless it is purely medical, then I think we may need a medical spokesperson. If it's the other issues, then a different individual, probably from human resources on the employment side. In terms of our planning for how we're going to do this, we really do need to have an infectious disease response plan. Most of your institutions will have those in effect, but this is an appropriate time to review and make sure that you really are at state of the art and are prepared to deal with the Ebola challenge as well as any others that are going to come up. And part of this planning process, again, as Dr. Petinaux said, we're going to have staff who are going to have concerns as we have questions coming in from the audience. We need to anticipate those questions about how our staff can safely treat patients, about whether they're going to be afforded leave if they have been exposed to an individual who may have Ebola. Are they going to be paid during that leave? What kind of benefits are they going to have? The time to start trying to address those questions, and I know that all of us who are speaking on this program today have spent a good bit of time already working with a variety of healthcare providers, trying to put in place the right policies to have answers to those questions and to have an organized framework for exploring how we're going to do that. And so things like that I would recommend to you looking to would be things about flexible work schedules. How are we going to pay for employees in these circumstances? What are our paid time off policies? How will they come into play? What kind of unpaid leave policies do we have? Anticipate the need for having answers in these areas to questions that we do not normally get. Now further, and again, giving comfort to our employees, again, the need for personal protective equipment, and as Dr. Petinaux described, this problem of making sure that we have the equipment and that employees are properly trained to use that equipment. It is not enough, and I'll get to OSHA in a moment, Occupational Safety and Health Act, The fact that we have state-of-the-art equipment available, if employees are not well-trained as to how to use that equipment, we fail. And so we need to make sure that our training is just as adequate as is our provision of the equipment. We've got to communicate with our employees about issues like not being in the workplace if, in fact, they're feeling sick, promptly communicating to us. And again, that's going to play hand in glove with the issue of how we are going to compensate those employees. If we do not give some consideration to compensating employees who are staying home sick, many employees will feel the need to keep their compensation flow steady, and they may choose to want to come into work even if there's some question as to their health. Well, we need a protocol to address that and to consider how we're going to deal with anyone, for example, who's presenting with a fever, understanding again that things like fever and the starting point, as the doctor described, very non-specific, but we need to think through how we're going to deal with those issues on the employment side. What are our protocols if someone is infected in our workplace from dealing with a sick patient? We need to think through that in advance. The legal concerns come from, unfortunately, a whole variety of angles that we have to face here. And as I've already mentioned, the Americans with Disabilities Act is certainly key in this. But let me outline and then look more specifically. We'll look at the federal level at Title VII of the Civil Rights Act of 1964. We'll look at state and local analogs in the anti-discrimination laws. We're going to look at the provisions of the Family and Medical Leave Act, and again, state and local laws which provide leave to individuals. Workers' compensation, as George was mentioning, comes into play here for illnesses and injuries that arise out of and in the course of employment. We have to be concerned with any perceived retaliation against an individual because they have reported that they don't think that we're doing an adequate job of protecting employees against Ebola, or for a variety of other reasons. Our health and safety laws at the federal level, Occupational Safety and Health Act, and again, some of the states being in the picture here, our wage and hour laws. How are employees entitled to be paid under the wage and hour laws? And then we have to also be concerned with union activity, complying with existing collective bargaining agreements, and the National Labor Relations Act. Now, more specifically, let's look at the ADA. We mentioned the connection here from providing care, but what on the employment side? Well, we know that we may not discriminate against an individual who's a qualified individual or applicant with a disability who can perform the essential functions. We know the three prongs of coverage under the ADA, those who have a physical or mental impairment substantially limiting a major life activity, those who have a mere record of such an impairment but no active disability, or those, and I think this is particularly significant in this context, those who are merely regarded as. The first question is, will Ebola be treated as a disability? It may very well be treated as a disability, although it tends not to have a long period of time where we are going to be dealing with this. After the ADA was amended in 2008 to remove the lengthier durational requirements to establish a disability, it is entirely possible, and if not likely, that Ebola will be considered a covered disability. And so therefore, if an individual suffers an adverse treatment in the workplace because they are regarded as having Ebola or potentially having Ebola, they could present claims under the Americans with Disabilities Act that would subject the employer to potential claims for compensatory and punitive damages, pain and suffering and punitive damages would be in the picture here. And in these circumstances, we have to be cautious as well because there is one other category of those who are protected, and that is the category of those who are associated with an individual with a disability. So if there was knowledge in our workplace that an individual may have been exposed to Ebola or has Ebola, and if that person has a spouse, a significant other, a child, someone they are associated with, we have to be concerned that there is no discrimination against such a person because they are associated with. Now, that does not necessarily mean that we don't take prudent health precautions with regard to someone who may be exposed, and we'll examine that. But we do have to very much think of the fact that the Americans with Disabilities Act is definitely in the picture here, And so we need to be concerned with what we're looking at. So what are some of the specific questions? Well, medical inquiries. We can't make typically medical inquiries of employees unless one of two circumstances is present. One, that it's a voluntary inquiry, and for the most part, we're not here going to be dealing with something that's voluntary. So then what are we going to have to do if we're making a medical inquiry? We will have to meet the test of showing that our inquiry is job-related and consistent with business necessity. And I think for those of you who are in healthcare providers, you're going to have to be able to meet that standard and should be able to meet that standard if the facts in a specific situation give you some apprehension because of the exhibiting of symptoms or other indications that the person may have Ebola, that then medical inquiries can be justified, notwithstanding the ADA. When we make those inquiries, however, a couple of things kick in. Just as we had the discussion from Amy about the HIPAA obligations, we have independent obligations under the ADA to maintain confidentially medical information that we acquire about an employee and keep it separate from the employee's personnel file and not to publicly disclose that information. The only individuals who should have access to that information would be individuals with a legitimate need to know. Who might that be? Those who would potentially be involved in the testing or treatment of such an individual. But outside of those few individuals, we would not have a basis for disclosure. Now, I want to mention a very specific defense that is provided under the ADA, the so-called direct threat defense. And that direct threat defense arises where there is a situation that presents a significant risk of substantial harm to the health or safety of an employee or others that cannot be eliminated or reduced by a reasonable accommodation. So given what we know about Ebola and the seriousness of EBD, I think we can say that the direct threat defense is one that is potentially applicable. But that's not enough, ladies and gentlemen. You still have to run through the 4 factors that have been laid out by the EEOC as to specifically using the direct threat defense. We have to look at the duration of the risk. Well, the duration here will typically not be long, probably through the incubation period. However, during that period of time, the nature and severity of the potential harm is obviously pretty elevated. And the likelihood of potential harm, well, that's the whole issue of why we need the appropriate protocols in place to make sure that we're not going to have transmission and why all the training and why the personal protective equipment is all necessary. The eminence of the potential harm, well, the likelihood of transmitting EBD if we do not take proper precautions, that leads us back to saying that because of the direct threat, we will have the ability to take certain actions that we would not normally have the right to take under the ADA. Now, the ADA is by no means the end of our considerations here. National origin discrimination is in the picture under Title VII. It would not be permissible for an employer to say, well, so to avoid potentially bringing on board employees who might have been exposed to Ebola, we are not going to hire anyone who is from one of the West African countries. That kind of block itself to the right to employment is not going to work. And so, anything where we are singling out those individuals where there is not an identification of specific factors that the person is posing some potential risk would be a problem. As to the FMLA, an employee tells us that they want to go to West Africa to care for a family member. If that individual is qualified, we would not have the right to refuse their going to West Africa to care for their sick family member. Now, when they come back, we may have protocols as to what happens upon their return, but their right to take that leave would be guaranteed by FMLA. We also have to be concerned at the state level. Many of our states, New York, California, and many others, have laws that prohibit an employer taking adverse action against someone for lawful off-duty conduct, and that could include travel. So we may have state law considerations in a number of our states that are in the situation. Whistleblowing. If someone reports what they believe to be unsafe conditions in our workplace, that would create some rights. An example, the New York labor law specifically prohibits healthcare employers from penalizing healthcare employees who disclose or threaten to disclose an activity, policy, or practice that they reasonably believe constitutes improper quality of patient care, or object or refuse to participate in such an activity, policy, or practice. OSHA. Clearly here we know the general duty clause and what an employer is required to do, which is maintain a safe and healthful workplace. OSHA has not yet put out any specific standards with regard to Ebola. They have put out a fact sheet, and of course their pre-existing bloodborne pathogen standards have some relevance here, although as Dr. Petinaux explained, we're concerned much more about other fluids, not just blood. But we certainly need to be following at least the protocols that the bloodborne pathogen standard would require. You see the protocol we need to run through here: risk assessment, providing training, informing employees if any of their activities will put them at risk, ensuring that they have the equipment, ensuring they fully understand how to use it, and generally having a policy of making sure our supervisors are on top of the present circumstances so that they are not putting our employees at an undue risk. We also have to look at points of contact as well as cleaning surfaces and our waste disposal. All of these are important in this particular situation. The FLSA, what's the issue here? Well, if we put employees, for example, we have someone and we tell them to work from home because we're concerned as to whether they may have been exposed. We need to make sure that if that is a non-exempt employee, that they're paid for all of their work time while they're out of work, and an exempt employee has to be paid for the entire work week if they perform any duties during the course of that work week. There are also state and local laws that apply with regard to employees being entitled to pay, so we need to make sure we're keeping up with all of those issues. Now, the National Labor Relations Act is in the picture here in a very big way. For large healthcare institutions, you will oftentimes have some employees who are covered by a collective bargaining agreement and union represented. We must make sure that when we put our protocols in place that we don't violate the provisions of our existing collective bargaining agreements, or that we negotiate with, that we inform the collective bargaining representative of policies and practices and have some discussion with regard to those. We may be mandated perhaps by either CDC or state health departments, but we should be putting any collective bargaining representatives on notice. Now, a different problem is, what if employees strike because they do not wish to perform services? And on the 11th and 12th, there were about 18,000 nurses in California who struck over a variety of issues, but some of them were saying that they did not believe they had adequate training or equipment available. We also had locally here Providence hospital nurses, again in the context of bargaining, but who did some striking. Well, if the employees are covered by a collective bargaining agreement, there may be a no-strike clause which they would violate in that set of circumstances. We would have the right to bring in replacement workers, however, to continue to provide patient care. What we could not do, unless the strike was in violation of a no-strike clause, is discipline employees. For those of you who do not have union-represented employees, though, I have to point out to you that the National Labor Relations Act also provides protection for what's called protected concerted activity, even where there is no union in the picture. And so we saw the example of the workers in New York at LaGuardia who refused to go to work when they didn't believe they had adequate protective equipment to clean the plane that had transported one of the nurses who had been Ebola exposed. So we have to be cautious here with regard to protected concerted activity. So all in all, ladies and gentlemen, what should we do? We have to be very cautious as we navigate the employment laws while keeping the workplace safe. We have limited ability to address a number of issues. Now, we've been giving you a number of questions. I'm not going to talk about all of them, but the first couple I do want to mention during the course of the afternoon's program. Can we require employees to disclose confidentially whether they have Ebola or have symptoms of Ebola or have been exposed? Normally, again, as I said, the ADA prohibits general medical inquiries unless voluntary or job-related and consistent with business necessity. Here, I think the employer can meet the job-related and consistent with business necessity test and or the direct threat defense because of the imminent harm that could be caused by exposure. So, yes. can we require employees who test positive to disclose confidentially the test results to the employer? Again, yes, for exactly the same reasons, that we need to be able to protect other employees as well as other patients in our institution, and so we do have the right to make that mandatory. A third question is, can we require an employee disclose confidentially whether she's been exposed to others who have tested positive? The answer here, again, is a yes answer because of our need to address that situation and make sure we're not creating a situation for further potential transmission of the virus. Can we require employees with symptoms to be tested? This one's a little trickier. I think the ultimate answer is yes, but again, we cannot do it based on fear of contagion, but it would be based on the actual symptoms. And if we see actual symptoms present, then I think we do have, under the ADA, we can show ourselves to have the business necessity and be preventing a direct threat. Informing colleagues only if the employee authorizes informing colleagues of the fact that they, Joe Smith, Mary Jones, have tested positive, would be in a position to do that. We may have the obligation and duty to let employees know that they may have been exposed and to take proper precautions and to be subject to screening and monitoring. Well, what we do not have the right to do is to say it was as a result of a particular individual. So we have to be cautious in that situation. And the last question I'm going to take during our program, can we inform coworkers or managers or supervisors that an employee has been exposed? As I said, without consent, the answer to that situation is no, we are not going to inform individuals without their consenting to do so. Can we require individuals to leave the premises? Well, if we believe that there is a reasonable threat that they have been exposed or have been contracted Ebola, then we would have a circumstance where we may be able to do that, but otherwise, no. So there are other questions that are out there on this issue, and we'd be happy to deal with those. You can email us with those kinds of questions. But there are an awful lot of issues. We talk about travel restrictions, and certainly the employer can prohibit its business travel. As I explained, however, because of the FMLA, we would not necessarily, for anyone who's FMLA eligible, be able to bar them from going to care for a covered family member who wants to do so. And again, the off-duty conduct laws, and we also have to be cautious about national origin discrimination. So employees who do not want to come to work, the issue here is under the Occupational Safety and Health Act, if they believe reasonably, and I stress the word reasonably, ladies and gentlemen, that there is an imminent harm, potential harm to their health or safety, then they are privileged under the Occupational Safety and Health Act not to come to work. But they must have a reasonable belief. And again, the general fear of contagion without some basis that there is a particularized threat would not supply that reasonable basis to believe there's an imminent harm.
Let me ask, we do have I want to try to get to audience questions, some of which we've dealt with during the course of the discussion. And one question that comes in, can you share any examples of what employers are doing to provide peace of mind to caregivers who are treating Ebola patients? And I'm going to ask both Frank and Dr. Petinaux to respond to that.
Certainly, I think training and education is really key. What we've done is we've really taken that focus with our staff to not just do general training and education about the disease, but we've really demonstrated even the operations as we're envisioning the operations to take place. Again, we've not had the opportunity to care for a patient directly ourselves, but we feel that it's very strongly that we don't just illustrate what we're doing, but for the staff to be able to walk through the physical space that we're planning on using, for staff to be really able to see the level of protection that we're doing, as well as the buy-in from the senior leadership of all of our operational and administrative levels to show that it's being taken very seriously at all levels. And that, we feel, has really done a lot in addressing our employees' concerns and having a very frank and honest discussion with them. Frank?
Yeah, I think that that's the point, which is frank and honest discussion. Communication is absolutely essential here. A lot of what we are dealing with is seeing to it that we are dispelling the fear because of the gravity of the potential harm that exists. And so really that's the circumstance I think that we have to deal with.
So there's another question, and get to that. Have hospitals in the U.S. that have treated patients with Ebola put their staff who work with those patients on limited duty or otherwise subjected them to any restrictions following the delivery of care to those patients? Are you aware of any, Frank?
Not specifically aware of that. I mean, there was a lot of ballyhoo about, several of the, particularly the one nurse who returned from treating patients in West Africa and the quarantine that the states imposed and some pushback with regard to that activity. That remains an issue that's sort of an open issue as to what the circumstances will be there. And look, you have to certainly look at your state or local health department requirements that may come into play with that kind of a situation.
We are at the conclusion of our program. I wanted to point out to you that we have in the materials a series of Epstein, Becker, and Green resources that you can look to for answers to specific questions. You will find on our website, and the links are reflected there, a client alert that was written specific to employment issues and how those employers ought to be dealing with and should be considering issues relative to Ebola. You will see postings relative to the Joint Commission, to OSHA issues, to FDA issues specific to Ebola, as well as issues relative to coding, coverage, and payment. So I would encourage you to look to these sources. There are additional sources to watch for. There will be articles in Walters Clower and Healthcare Risk Management report to further extrapolate on issues specific to healthcare providers and employers as they relate to Ebola. Thank you very much for participating today. Dr. Petinaux, thank you very much for joining us. We really appreciate you offering some thoughts to the audience. It was terrific. And thank you to the audience for joining us. We appreciate it and look forward to speaking to you again. Thank you.
Thank you.
Thank you for joining us. This concludes today's webinar. In approximately 2 to 3 business days following the webinar, Epstein Becker Green will communicate the availability of the webinar recording and access to the PowerPoint materials. Thank you.